Good morning, everyone. Thank you for joining us for our 5th annual Patient Safety and Quality Fair. My name is Rami Nakeshbandi. I'm the Chief Medical Officer here at SUNY Downstate, University Hospital at Downstate. First, it's my pleasure to introduce Dr. Pat Winston, our Interim Chief Executive Officer at the University Hospital at Downstate. Dr. Winston was appointed as the Senior Vice President for Hospital Operations at the University Hospital at Downstate in September 2020. After she had an impactful 18 months tenure as an interim CEO, during which she successfully led the hospital through one of the most challenging global health crises in the recent history. Her leadership was instrumental in guiding both hospital staff and the broader healthcare system through unprecedented challenges, while working closely with the public health officials and the leadership teams across the state. Pat's commitment to healthcare excellence and community service has earned her several prestigious recognitions, including awards from the American College of Healthcare Executives and the National Association of the University Women Community. She also has earned the Crane's integral list of notable women in healthcare and the Network Journal 25 Influential Black Women in Business. Dr. Winston holds a doctoral in nursing practice from the George Washington University, a Master in Science degree in Healthcare Administration from Westchester University, and an RN diploma from the Nursing School of Wellington in Delaware. She is board certified in nursing administration, and she is a fellow at the American College of Healthcare Executives. Please join me in welcoming Dr. Pat Winston to give opening remarks for this event.
Good morning. When I hear things like that, I wonder, is that me? My Lord. Now, you know I started all that when I was about 5, so just in case you're trying to add years. Well, welcome to our 5th annual Patient Safety and Quality Fair here at Downstate Health, University Hospital at Downstate, and known to all of you as Downstate. Thank you for joining us today. There's something for everyone, from our speakers, our panel, our posters, and our breakout sessions. So as long as you can stay, that's how much more knowledge and fun you're going to have. I just want to share with those of you who don't know who Downstate is, just a few facts about us. First of all, we're the 4th largest employer in the borough. We provide high quality care here at our Safety Net Hospital. We're the only academic medical center in Brooklyn. We have the only transplant center in Brooklyn. But most important to us, and our biggest asset, is many of you who work here, our doctors, our nurses, our support staff, our ancillary staff, and the fact that we all practice our We Care values. And for those of you who don't know what they are, we'll tell you. The acronym is We Care, but we're welcoming to all. We believe in equity, collaboration, accountability, respect, and excellence. Thank you, and enjoy your time with us today.
Thank you so much, Dr. Winston. This event truly holds a special place in my heart. So since we start the first event in 2021, we come a long way. I remember in the first year in 2021, we had to start our first patient safety event as a virtual event because of the pandemic. You can imagine how difficult and how challenging that was. Since then, we had almost close to 200 posters, including posters related to quality and patient safety, and it reflects our commitment to quality and patient safety in the institution, represents our journey to high reliability. We have presentation from leaders across New York City and nationwide, covering topics such as AI and innovations impacting quality, staff burnout, quality and patient safety in challenging healthcare landscape, and risky business, quality, equity, and essential hospitals, and many, many others. This event has consistently demonstrated the engagement of our staff, the commitment of our leadership to quality and patient safety. It is truly a pleasure to guide you through today's event agenda. But before, I would like to take a moment to thank some of the key individuals. First, I want to express my gratitude to our leadership. Dr. Wayne Riley, our president of Downstate, and Dr. Pat Winston, our interim CEO, who consistently prioritize quality and patient safety in the top of our agenda. I would also like to extend my thank you to the incredible team who worked alongside me to make this event successful. Dr. Lillian Ju, our Director of Patient Safety, Dr. Cindy Benson, our Interim Director of Emergency Department, Paulina Botang, our Chief Experience Officer, Shay Walter, our Director of Quality, James Grozantes, our Director of Marketing, and Taishan Tony, our Director of System Engineering, and many, many others who put so much time and effort to make this event very successful. Lastly, special thanks to Eileen Jesse and her team. She paid meticulous amount of details to make this event as a level of a national conference. Today's fair is a day full of events. So we'll start first with a powerful panel discussion about leadership in crisis, followed by a keynote presentation on innovative ways to promote staff engagement in quality and patient safety activities. Both events will be held in this auditorium. Afterward, we'll move to the Fab Hall in the Public Health School to attend the poster session and the breakout rooms. Those breakout rooms will be discussing innovation and AI, culture of safety, Joint Commission tips, patient experience initiatives, and impact of care management on quality and patient safety. Then we'll have some kind of break and refreshments back here in this area, and followed by oral presentation on 4 impactful PI projects. We will conclude the event with an announcement of the winners for the posters and the oral presentations. Thank you all once again for being here, and I look forward to a great day ahead. If you have any questions or if you need any more information, our team will be around to answer your questions. To kick off today's Patient Safety and Quality Fair, we are excited to present a panel discussion on leadership in crisis. Healthcare leaders are often faced with unprecedented challenges, whether it is managing a pandemic, responding to cybersecurity threats, addressing financial challenges, or navigating other crises. Effective leadership during those times is critical to ensuring safety and quality, not just to the patients, but to our staff. Today, we will explore how leadership responds in times to crisis, the strategies used to maintain high standards of care, and the long-term impact of such challenges on healthcare systems. We have leaders from across New York City and New York State, and I'm pleased to introduce the moderators for this event, for this discussion. Dr. Cindy Benson, the Interim Director of Emergency Department, Jamie Greco, our Chief of Human Resources and Interim Chief of Staff. Both Cindy and Jamie bring valuable perspectives and expertise in this conversation, and I look forward to having the insights that will guide the panelists through. Thank you very much, Dr. Benson and Jamie. And I'll invite our panelists to the podium.
Good morning, Downstate.
Good morning.
Let's get started. I'm excited for this conversation. Mr. Doyle, this first question is going to go to you. Literature has shown that environmental disasters impact medically underserved communities disproportionately than other communities, and that's due, theorized, to a lack of public health infrastructure. So we know that's a fact. However, when disasters are planned for and surge capacity is planned for, the fact that there are healthcare disparities is not usually kind of built into the programming, knowing that some communities are going to require more resources. So given the fact that we've had such a significant increase in domestic natural disasters, such as wildfires in Hawaii and LA and Canada and New York City, New Jersey last summer, as well as the hurricane, for instance, that devastated the Baxter plant, are there any proactive strategies, such as IV fluid conservation or things in that nature, that organizations should implement now in order to minimize the impact on operational processes in case there is a disaster? And as you plan for institutional or system growth, does the level of disparity in a medically underserved community alter how or what you plan, or should it?
Okay, well, thank you for the question, and thank you for inviting me here this morning to speak and participate in this panel. The question posed about disparity and how that orchestrates response to disasters. We, in healthcare, we know this, I'm sure this room is well aware that preparation and response are how we manage disaster. Or unforeseen events when it comes to disruption of our healthcare delivery system. It's important to maintain the level of safety and quality to the healthcare system, to our patients, for our staff, and to what we deliver each day, even when facing unexpected events such as disasters. Ways to prepare and begin to reorganize our healthcare delivery system in various regions throughout the country. And New York City is an area, Brooklyn for sure, that we work in here for some years now, almost a quarter of a century, actually 25 years in Brooklyn, in partnership with our colleagues here, some at the table. Coalitions are very important. Establish true coalitions, collaboratives. We have those in Brooklyn. Those are sometimes required by Joint Commission and New York Department of Health and Mental Hygiene that we participate in drills. We participate in communication drills in addition to scenarios presented by the various organizations, and we collaborate on those on a coordinated routine basis throughout the years. These are scenarios that are presented. Mass casualty typically are the scenarios that are presented in this region, as well as communication failures. We're beginning to turn a mind towards supply chain, and we remain vulnerable. I think system approach, being part of a full system and having the support of a healthcare delivery system, not being a standalone hospital that's relying on coalitions that are less formal than being part of a system, can mitigate or help manage that. So the stronger we are regionally as partners and work and collaborate and support our colleagues and our partners in coalition regionally, as informal as those are, until they become more formal and required, is a way to begin to prepare for that. Managing when you don't know what's going to happen, like preparing when you don't know what's going to happen, can prepare us with cause us to be ill-prepared. We're reactionary when it comes to what happened with the IV solution specifically. Having the team review the processes and be able to communicate throughout and clearly with the entire care team, and communicate any change in the process as we make those changes to the delivery of care. Managing the IV solution is again another example that we're familiar with. The medical teams work very closely on how to repackage in certain ways safely, and how to reutilize or how to utilize volumes or packaging, and also how to conserve. And we realize in healthcare we waste a lot. We have a lot of waste in our system of just materials. We look at our prep in our ORs, and we look at what's laid out in those areas. So managing waste in our systems and having an approach on our infrastructure our generators, our ability to support ourselves when we have power outages or affected by other natural, we'll call them disasters. It seemed to be way more frequent and seemed to be impacting us more and more. And again, going back to the top, we're required to be prepared in order to provide the safe, quality, consistent care throughout an emergency. And we've seen examples of that. Best ways are to drill and have collaborative coalitions in when there is no formal health system in place in the region. And we can, draw, any, sort of examples of that from our local region, et cetera, who's more advantaged and who is less advantaged when it comes to that. But certainly the systems are stronger, bigger systems have advantage over certain other parts of the local region. So I'll pause at that. I don't know if that helped. Was that?
Yeah, no, that was great. I think picking out some themes, it's important to have, I think we're going to see these themes throughout the panel, but important to have good communication, to prepare by drilling, because that's how you kind of cement the action that is to be taken, and then just identifying and decreasing waste as much as possible in advance of a disaster so that you have more on hand.
Right, and to speak to the purpose of the panel of leadership throughout a disaster and a point is right. Communication with the team, being present, rounding from leadership rounding when we're faced with external pressures and sometimes internal is so key. Been available, senior leadership, been available on the floor, been able to communicate consistently and regularly the status of the emergency. We have to remember that our staff can be impacted outside of the workplace by these disasters. In some scenarios, by the storm, Superstorm Sandy, et cetera. The staff were impacted by that, not able to get gas in some ways to get to work, or some people's homes were flooded in various parts and impacted by that, and their families throughout the local region. So supporting staff with information consistently and with presence and executive leadership and leadership presence is very, very important throughout that. I'm sure we'll talk about that as we talk through other parts of the panel discussion this morning.
Excellent, thank you. Mr. Greco? Thank
you. Dr. Winston, this question is for you. Regarding infection, COVID, avian, RSV, flu, measles. An April 2021 Lancet article stated that two of the biggest drivers of reemerging infectious diseases are social and health inequities. Data show that low-income and high minority prevalence areas like Brooklyn were the most devastated by COVID-19. So, how does prior pandemic experience inform decision-making for the next pandemic, given that one doesn't know what will be needed? Are there best practices that can be applied no matter what infection is at hand?
Thank you for the question. When I was asked to be on this panel, it brought back our COVID experience here, and many of you were a part of it. I think as a result of what we went through, preparedness and accountability are key to saving lives, and that'll work for any pandemic, and I'm sure nationally now we're calling, we have a pandemic playbook that people are playing by. But some of the key things I thought, and I'll compare that to what we did, early detection and surveillance is one. Having global and local monitoring, genomic sequencing, that's what helped them get the vaccine developed so quickly, even though some people didn't trust it and thought bleach was better, but there were different things that were important to us, and transparent data sharing, rapid response and containment. We're in an old facility. Many of the facilities in Brooklyn are old, so we don't have all isolation rooms, and I remember the plastic we used to isolate our patients, and that's important, to isolate and quarantine and do contact tracing. That's what helped South Korea contain their virus, because they did contact tracing. And we got through that. And let me just say, all of these things I'm talking about, we did pieces of here, but we did it as we were going, not really knowing what we were exposed to, but just working very hard together to figure out what the heck is going on. Travel policies, you know, everybody knows they put travel policies in place. PPE and supply chain readiness. Now that part was very scary. We can say stockpile, but this stuff expires. You know, so you have to have a supply chain that has those resources and use those supplies. If not, they're going to be out of date. And I remember we went through this, and we had to have the city or state said we had to have a 90-day supply. We had to turn that over. The other thing we got lots of supplies because people pulled together and they wanted to, but they weren't hospital grade. You know, so what do you do with those? You know, you use them for teaching and that kind of thing, but we got enormous amounts. Now, we couldn't let the public, and we stored it, because we couldn't let the public think we weren't grateful and that we didn't want those supplies, so they couldn't see that, you know, we couldn't use them, but you don't put them in the trash bins. But, I mean, that's real important to figure out how to manage the supplies when something like that happens. Hospital surge capacity, you know, healthcare system preparedness. Until that hit, I didn't realize how quickly you have to move in that environment. We were designated COVID only, so we had to get all the healthy and close to healthy out of here and prepare COVID hospital. We had to just have every room, every space we had, and we were asked by the state, it's kind of disjointed a little, you know, to prepare so many beds, and they said they'd help us stand these beds up. Now remember, these are semi-private rooms, and that really didn't happen. The ICUs are open, so they promised that. That didn't come to fruition. That's why we had to use the plastic, but you just learn and do as much as you can. During that time, cross-training the docs. We had docs from all different specialties helping to take care of these patients, and it was scary. And Cindy, you remember, I mean, you were a part of that. We had all kinds of physicians trying to help us take care of these very, very sick patients that we didn't know what was going on with. We had families scared to death. We had a big room full of valuables. People thought they'd catch something, so they, you know, wouldn't come and pick up the valuables. And at some point, we had to get rid of all that. I mean, it was a scary time. Telemedicine, we got into that business. And that's, you know, during COVID, that's when telemedicine skyrocketed. I mean, and it's important, and you use it now, it's a good thing, but it took COVID to say, guys, think there's another way to, whether it's educating people in school, whether it's seeing sick people, or however you do it, you can do it that way. Meetings, now some of us enjoy it so much, we're having a slow time coming back to the office. However, it works. Public health communication. All of you were a part of this. I mean, and I'm sure it'll be, well, I'm not so sure it'll be better going forward, but, you know, consistent, scientific-based messages to people to say, what should you do during that time? Not just, you know, everybody, you know, doing whatever. Engaging community leaders and influencers, people that people listen to, you know, people that look like you or act like you, to tell you, you know, it's important to wear a mask. It's important to get a vaccine. It's important to be safe. You know, if you don't want the vaccine, just try to be safe. You know, encouraging, having people behavioral health guidelines, like, you know, if I get to know you and I know you, you'll listen to me and you'll do what I'm doing, you know, and to have those kinds of things happen. And the other part of behavioral health is to have people available to help people through all this. I mean, and that's terrible. And that, I think that's kind of the biggest fall down for me, because people are still suffering. People are still scared. I mean, listen, I'll whip out my mask in a heartbeat. Even look like you're going to sneeze and I'll grab a mask. Vaccine development, you know, having these, they said in the literature that the way we were able to manufacture that COVID vaccine, again, that people thought was suspicious, was using adaptive vaccine platforms. They called it mRNA. And that enabled us this time to have the COVID vaccine, and we need to make sure we have those so that we can do that going forward for future whatever happens, whether it's measles or whatever. And I'm not a scientist, so I don't know that part. Regulatory pathways, streamline the approval process for who can do what. You want to keep people safe, but you want to be able to bring in healthcare providers, and we had some of that to come in and help take care of these patients because you approve it really fast. And global distribution of vaccine. We weren't, some people got, some people didn't, but to make it equitable so that you don't have these variances, these vaccine variances emerge. I only have a couple more, so then you can take a break, I guess. And breathe. Economic and social support. We talked about remote work and education. We didn't talk about mental health resources, for stress, burnout. I mean, look at the pictures that were on the news for how people looked and they were tired and exhausted. International collaboration, with CDC and who as we know them now. And regional alliances to see what we can do. Legislative readiness, and that's a big one, so we'll see what happens. But these are all the kinds of things that will help us be better prepared going forward, knowing that, having lived it, and knowing these things will make us better for the future, hopefully. Thank you.
Thank you.
So you did hit on the communication theme, which I think is going to come out of this. Also, I picked out innovation in a couple of different ways, both in the scientific community, utilizing healthcare delivery systems a little bit differently. But I also like that one of the takeaways is going back to the basics with something as simple as contact tracing, not that it's simple. In principle, something as simple as contact tracing that becomes a very effective strategy, especially when there's an unknown thing that we have yet to fully figure out. So I think it's kind of you pulled out a nice blend of some of the tried and true strategies, but also challenges to be creative and problem solve in innovative ways with good communication around all that. You'll see this is definitely a passion. Okay, Dr. Wei, next up. So in 2022, the Surgeon General published an advisory titled Addressing Health Worker Burnout, the U.S. Surgeon General's Advisory on Building a Thriving Health Workforce. In that paper, there are some statistics listed stating pre-COVID, so before any of the pandemic hit, 35 to 54, not 55%, of nurses, and 45 to 60% of medical students and residents reported burnout, which, as you well know, is an occupational syndrome characterized by a high degree of emotional exhaustion and depersonalization. So the question for you is, you've demonstrated through the creation of H3, Helping Healers Heal, that staff wellness is mission critical for any institution. Given that post-pandemic staffing is one of the greatest operational challenges we all face, are there other strategies that can be employed to improve staffing, retention, and engagement? And are there different strategies to address leader burnout, or are the strategies employed there the same as frontline staff?
All right, thank you so much for the question, and thank you for having me here for this panel. Wishing all of you a happy Patient Safety Fair. I feel like I'm cheating a little bit on this question because I was in DC yesterday at the National Academies of Medicine, and Dr. Murthy actually spoke there as well. But today is actually the second annual Healthcare Workforce Wellbeing Day, and so wishing all of you a happy day for that as well. But I think what the panels yesterday that I took part in really drove home is we've come a long ways. Just the fact that there is recognition, there is the Surgeon General's map or roadmap for this. National Academies of Medicine has also created a playbook for any hospital, clinic, health system that wants to address clinician well-being. But when I started helping Healers Heal a little over 10 years ago, there wasn't really a blueprint. We really had to build it from the ground up. And for me, it was when I first became the deputy CMO at LA County USC, and they said, congratulations, now you have to run our RCAs. I had never been to a RCA. I had no idea what RCA stood for. Somebody told me it meant root cause analysis, and so I went to Google. I typed in how to run a root cause analysis. But the first one really left me kind of shaken with a pit at the bottom of my stomach. We brought nurses, we brought residents, we brought attendings to tears or the verge of tears, reliving a nightmare case of theirs that's probably caused them to not sleep, to not eat, right, to constantly be replaying this case over and over. And then we would pat them on the back after an hour-and-a-half meeting and say, now go back to the operating room and do perfect surgery, or go back to the ICU and pass meds perfectly. And I knew, they knew, everyone in the room knew they couldn't do that. They were compromised, right, because of second victimization. And so looking around the country, I was like, there's gotta be, right, a model out there for us to create something to better support our staff, and there really wasn't. And today there is. So we've come a long ways. But yesterday also really drove home that we have a long ways to go. We are in an existential crisis with burnout of all disciplines in healthcare, right? How we're already at a staffing shortage, you know, going into the pandemic, and it's exacerbated by people saying, okay, that was my last rodeo, I'm retiring, or I'm gonna find something else to do. So we all know how hard it is to find nurses, to find physicians, respiratory therapists, even, you know, lab technicians. And so we're in an existential crisis, because if we don't change paths, we're not going to be able to keep all the hospitals and all the clinics open. And so first, I think, is acknowledging that we have a problem, not just a problem, a major crisis. I think as a leader, right, the most important thing is kind of swallowing that ego, admitting that you don't have all the answers, and having the humility to ask all the people in this crowd, in this audience, all the people that work in this hospital, you know, what do you need, right? I think there's a few buckets, I would say, that could kind of turn the tide. So one is addressing the anxiety, the stress, burnout, the mental and psychological toll, and being able to provide support. So H3 is based off of the concept of we give our patients and their families our healing powers all day, every day, freely, right? But the culture of the House of Medicine almost made it impossible for you to give it to your peers. Nurses eating their young, right? The attendings telling residents that I walked barefoot in the snow uphill both directions to the hospital and worked more hours in the week than there are in the week, so what do you have to complain about with your duty hours, right? We need to change that culture of the House of Medicine to be able to turn that healing power towards each other, right? I've been told way too many times that don't we give them good health insurance? Don't we have an EAP program? Like, why do we need more, right? Imagine being in a dark place, maybe even signs of depression or suicidal ideation, and being told, call the number on the back of your insurance card, right? That's just not good enough. So programs like H3 to address the emotional and psychological support, there needs to be system work, right? There's no amount of yoga and meditation that's going to make up for the moral injury, for the burnout, for the stress, the anxiety, the compassion fatigue, right, the vicarious trauma that we accumulate working in healthcare. The things that we see day in and day out are not normal. You don't talk about that around the, you know, at the restaurant with people who aren't in medicine, right? And so being able to put programs in place that are proactive, that address the 8 dimensions of wellness. You know, not everyone's going to need all of those, right? But making it available. But most of this is systems work, right? Why does somebody like my wife have to go home and after all of our kind of putting the 3 kids to bed, whip out her work laptop and have 2 to 3 hours of epic pajama time, just so that she doesn't carry notes into the next day, right? Can AI help us here? Is there technology that helps us not have to spend so much time typing, right? We didn't go to medical school, we didn't go to nursing school to be typists, right? And so can AI listen and be able to create our notes and our orders for us? I'm really excited about this ambient listening opportunity. Another thing that's really frustrating, that leads to a lot of patient safety and quality events that are traumatizing, is somebody is complex, they have a really, really large record, right? I have about a minute before I go see that next emergency medicine patient or emergency department patient. It's just random if I pick the right notes to open, right? Can AI summarize all of that into one paragraph for me and say, this is the most important things out of these thousands of pages of notes that you need to know before you see this next patient, right? And so we need to use what's worked for quality improvement for addressing patient safeties, like reducing CALDs, CLABSIs, falls, pressure injuries. We need to use that same rigor and that same engine and apply it towards what's burning out our staff, right? And then really listening to our staff about, what would they like to see changed, right? But I think the leadership lesson here is swallow your ego, have the humility, have the listening sessions, have the uncomfortable, difficult conversations, and through that, let's partner together to make this better.
Excellent, thank you.
Okay, Dr. Scott, this question's
It
for you.
must be me next.
Okay. It's well established that medical reimbursement does not fully cover the cost of care. And we all know that. With safety net hospitals often facing significant financial challenges, especially during times of crisis, what leadership strategies can be implemented to ensure that these hospitals remain operational and continue to provide essential care even under financial strain? And how can leaders balance fiscal responsibility with the need to maintain quality patient care during such a crisis?
Well, that's literally the $2 billion question, isn't it? Thank you for the question, and thank you for having me. And I want to take note that there are 3 emergency physicians on this panel, which is in and of itself, in my lifetime, a remarkable change and leadership in medicine. So I want to start off by saying the most important thing, and you framed the question around safety net institutions, so I'll frame the answer in that way, is to stay close to your mission. Human beings need purpose. Organizations need purpose. So one of the most important things a leader can do is to ensure that the workforce, the organization, understands its purpose. And once you understand your purpose, that helps to drive the operations to deliver the service. We are in the business of providing service to improve the health and wellness of the communities we take care of. And at the heart of that care is patient safety and quality. So at the end of the day, institutions need the community to choose to walk through our doors because we're in the business of delivering healthcare. So like any other industry, we want our customers to choose us. We want our customers to have good service, good outcomes, and to be happy with satisfied with the services that we provide. That leads to financial stability and wealth. So even if the reimbursement from Medicaid remains less than $1.20 on a dollar, right? Even if it remains at 70 cents on a dollar, 65 cents on a dollar, if the community is choosing to walk through your doors and they're receiving quality care and they're satisfied, they feel heard, they feel seen, they feel cared for, then you're providing the service that you aim to provide, right? And at the end of the day, if you're able to do that as an organization, then those in the state, federal, and city government will support you, right? So if you're chosen by the community, you're delivering high quality, safe care, at the end of the day, you're not replaceable and you can't close because you have a purpose and the community is choosing you. I think that's extremely important. If you're requiring subsidy because of the way reimbursement is structured and the community is not choosing you, then you're in trouble. The institution is in trouble. So the next thing I would say, which is in line with what the other panelists have spoken about, is change is absolutely necessary. There's no avoiding change. We as individuals are changing every day. Our families are changing every day. Our communities are changing. The environment is changing. It's not about what if we have another disaster. we're going to have another disaster. We're going to have another disaster. That's the nature of the environment that we're living in today. Finances will change. Reimbursement structure will change. Therefore, the organization has no choice but to change. And I think one of the major responsibilities for leaders in healthcare is to shepherd organizations through change. The new buzzword for change is transformation. And in full transparency, One Brooklyn Health is under transformation. SUNY Downstate is under transformation. And that means, similar to how the environment is changing, you as individuals are changing, our political dynamics are changing, our organizations must change. We cannot continue to deliver healthcare in the same way we did 10 years ago. So if you look at your organization and you say, how can patients schedule appointments with us? And you look at what's the scheduling process? And you compare that to what you did 10 years ago. If there is a lot of similarities in how patients get appointments, they have to call, somebody has to answer the phone, somebody has to look in the computer system and find the next available appointment, right? Maybe you send a text reminder or not. That's a pretty old paradigm, right? To your point, how did doctors used to take notes? We saw a patient, and then we sat down, and we wrote. People finally figured out we couldn't understand what the doctors were writing, so they made us type. Now we're typing more and more and more, and the typing is no longer feasible, so now we need technology, right? Doctors can't continue to document in the way that we did 10, 15 years ago, right? Ambient technology is one solution, but that's probably not the only solution, right? That's probably not the only solution. We're finding a solution that kind of sort of does for us what we were doing in the past. But is there something completely innovative about the way we document a patient-physician encounter? Can we do something that's even more, innovative, right? Like, of the work, so you described having a ginormous medical record as an emergency physician that you're expected to review. The patient expects you to know everything in their medical record anyway, right? You're expected to review it, have the encounter, gather all of this information about the individual, put that on a piece of paper, and then carry on with your medical decision-making. But that seems kind of bananas to me, because the question is, what percentage of the information in that ginormous medical record is relevant, right? Some of it is relevant for regulatory purposes. Some of it is relevant for billing purposes. Some of it is relevant to communicate the patient's condition so that the next care provider can kind of pick up where you left off. But truth be told, most of it is repetitive and not actually relevant. Right? So what if we thought about, well, what is relevant, right? And what is relevant for the physician to document and the nurse to document? What percentage of what's documented by the nurse and the physician is the same thing, right? Every single person who's taken care of a patient has heard the patient say, but I already answered this question. Who hasn't heard that? Why are you asking me the same questions over and over again? That's a reasonable question. Have we answered that question? Have we created innovation so we can stop asking the patient the same question over and over again? Right? No. We're creating technology to do what we used to do, which is document the same, ginormous volume of a medical record. So I think, to summarize for you, transformation is a necessary component of life. Change is a necessary component of life. Financial stability comes from effective business management, right? And for us, delivering high-quality, patient-centered care, right? Making sure that our communities choose us. And then we have a responsibility to do the dance that we're required to do to get reimbursed for the care that we provide. So that's how I would answer your question.
Great, thank you. I picked a lot of things out of that. I think, again, there's sort of themes in all of these, but innovation, figuring out technology. I like the idea of not just using technology to do the same thing you did before, but actually using technology to be innovative, and then how you communicate that, obviously, throughout patient encounters, but throughout systems is an important lesson. And I really enjoyed that the leader's job is to shepherd organizations through change. I think that's kind of the key message in this panel, and then figuring out how to do that in the overlay of crisis, because I think the amount of change that we experience often feels like crisis, and figuring out when it is and when it isn't is a key mission.
But so, I mean, yeah, I'm sorry, but is change really a crisis?
Sometimes.
Right? I mean, sometimes it is, but I think we think all change is crisis, oftentimes in healthcare, because we're so resistant to change. When someone imposes change, we feel like we're in a crisis. Eric?
No, on this change thing, somebody brought up yesterday that their favorite T-shirt is a Dilbert cartoon that said, "Change is good. You go first." Right? I just want to also add, building off of Sandy's comments and her prompt, New York City Health and Hospitals, when Dr. Katz and I joined in 2018, everyone was like, you're crazy. Like, this is career suicide. Why would you take over a failing safety net system? Not just a failing safety net system, one that's the largest in the country. And so H&H's budget then was $6.5 billion a year. It had a $1.8 billion structural deficit. That meant after all the subsidies, all the revenue, the city still had to come up with almost $2 billion to keep it from going under, right? All these consultants came in, multi-million-dollar analysis, right? Reports, close hospitals, stop hiring, backfilling staff, right? It's 80% of your costs. And so it was in this death spiral of, if you're not backfilling nurses and doctors and respiratory therapists, right, then you have nurses covering 20 patients, right? And then what kind of care are you providing? And as Sandy said, there's no glory in providing bad care, right? And no elected's gonna go to bat for you. But we actually closed that gap, even with the pandemic. We get $2.2 billion more in revenue today than we did in 2017, right? And it was from growing out of it. Investing our most precious resource, which is our people, saying we have your back. You don't have to worry about this hospital closing or this clinic closing. Let's work together on the revenue cycle piece, right? Why is it that we haven't changed our reimbursement rates and we haven't sued United Healthcare and others that even with the poorer reimbursement rates haven't paid us? And then what are business plans that we could put together that will help subsidize the other care that we know we can't make money off of, like behavioral health and so forth, right? And so we have very successful business plans across all of our hospitals that have helped create. So revenue cycle growing business plans have created $2.2 billion more in revenue. And so I think just because you're a safety net doesn't mean that there isn't a way to become kind of, in the black. Of course, we still depend on disproportionate share, DISH, on upper payment limit, right, and the support of our electeds for a lot of our capital things. But it is quite a turnaround to the point that the state's asking us if we want to take on more hospitals. So quite a story, and it shows kind of a lot of things that Sandy was mentioning.
And that's a journey. That's a journey, yeah, that you have to be willing to take.
Yep.
Yes.
I'd just like to add to the comment about change. Change is change, and I agree with you, Sandy, that it depends. People are resistant to change, but also I think sometimes it can be chaotic when it's not organized. I'm not saying that you don't look at it, but if you don't have strong leadership and be focused and structure that change, it appears chaotic to anybody who has to respond to that. So I think that's more the thing. The chaos is created when there's disorganization.
I'll just add one thing that doesn't come up all. Go ahead. Yeah, applaud for that. Add one thing when it comes to change, but trust. People trust in change when they know the direction that the transformation, as the word and the popular word is for change at the moment. The trust when the vision is known, the trust when the values, as Dr. Scott mentioned, our mission, our values, are known throughout our organization. So we know what we're about, we know what we're here for, we know who we're here for, and we know that we're here together. And we can trust we're well fortified, we're well positioned, we're standing on a foundation of change that can be meaningful. And yes, there'll be bumps, and yes, there'll be uncertainties, but moving in that direction, moving teams in that direction, leading in that direction, if we can demonstrate and earn trust with our partners as well as our teams, then we're on to something.
I just want one last comment on this. So we have these disruptors. You know, there is value in healthcare, and what we do, I call it a calling. We take care of people, we meet their needs. However, look at the CDSs and the other companies, especially out west, they've gotten into taking over facilities. H&H had a strategy, they worked towards it and they did it, but out west, they're worried about people taking the business from their big systems that were cumbersome. So there are all kinds of people out there who are anxious to help, and of course the people like CVS and Walmart and all those people, I mean, they have the funds. We need to figure out how to grow some funds so we can take care of ourselves.
And I mean, I think another important point that the collaboration has to also be between institutions, right? So particularly in Brooklyn, I think a new paradigm has to be not just at this level, right? Because if you get us around the table, I guarantee you, we've already met, all of us, like what can we do together, right? So that we're not duplicating resources. Given the financial constraints that we're all under, how can we work together? Because our missions are aligned across all of the institutions that are represented here. We want to take care of the community. We want better health outcomes, right? We want to make sure that life expectancy is equitable regardless of your zip code. We kind of are all on the same page about that. So what has to happen for the financial viability of all of us is we have to work together. And that's new. Work together beyond this table. It means on your level, right? How can you spark an idea so that we can work together to deliver the service to the communities that we serve?
Excellent, thank you. All right, we have two more questions that are, does anybody in the audience have a question at this point that they want to bring forward? If not, then what we were going to do is ask everybody on the panel the same question. We're going to start with a definite hot topic item, which is violence. So AAMC News reported the Bureau of Labor Statistics, this was from, it was published last year. The Bureau of Labor Statistics showed that the rate of injury from violent attacks against medical providers grew by 63% from 2011 to 2018. We also know that there was a recent murder of a healthcare CEO, which displayed that there's a section of the population that is so frustrated with the healthcare system that violent extremism has become a concern for all of us. So how does these things change the quality of care that is delivered? And how can leadership in healthcare respond to this growing threat? Are there strategies that can be put in place to protect healthcare workers while ensuring that the violence doesn't compromise the quality of care that's delivered to patients? I think since we went this way, maybe we'll go this way, just to change it up, and the next one will come back around. So Dr. Scott, please.
Well, I mean, that's a very complicated question, because the increase in violence is due to changes in the dynamics largely outside of our institutions. And so that is going to necessitate collaboration with those institutions that help to control the dynamics in the community that result in increased violence that then bleeds into our institutions. But one of the things that is top of mind for me is reestablishing our healthcare institutions as sacred places, right? So churches don't have the same kind of problem. And I believe that healthcare spaces should be sacred spaces, and we should create that belief and comfort in the community so that they respect the healthcare institutions as their own home, right? And so, although some people are violent in their own home, but in general, you want to make sure that the community sees us as a safe place and they respect the healthcare institution. I think that's slightly at the heart of the problem, right? We know that there has been historically hospitals are not to be bombed during war, right? We have international policy that protects healthcare institutions. So why do we not have the same paradigm in our communities that we are serving? So I believe that a key component to reducing the violence within the walls of healthcare institutions is to change the perception of the role of the healthcare institution within that community.
Yeah, this is something that definitely keeps me up at night. And I remember, when we had the shooting in the Jacoby ED a few years ago in the waiting room, and the staff were very scared, and they were very honest on these listening sessions. And they said this should be a never event. Anytime a healthcare worker is, verbally or physically attacked, it should be a never event, and we should take it as seriously as the NIPORT's mandatory reportables to the state. We should be doing root cause analysis, and we should be looking at what the root causes are and putting in corrective actions around that. And so that is something that we're doing at Bellevue. I think many of our H&H facilities are doing it as well. I agree with Sandy that this is right, especially the emergency department is not just the safety net of the safety net, in our systems, but it's for everything that's broken in society ends up at our doors, right? We take everyone without exception. It's always open, right? And it is, right, severe mental illness, it's substance abuse, it's the stress of, right, socioeconomics, the pandemic. We say, right, it's caused people to be deranged in a way that there's this quick to violence, more than before, and we're seeing it across the globe. I was in Singapore a few years ago giving a talk, and toured their emergency department, and it's the same sign that we have in our hospitals there about not attacking healthcare workers, and so this is a global crisis. Some of the things that we found very helpful, we created a new discipline called behavioral health associates. So we have hospital police, but a uniform can be triggering as well, and it means different things to different people based off of their past experiences. And we have, right, physicians, nurses, psych techs, but everybody is really busy with all the other responsibilities they have. The BHA's, their sole responsibility is to monitor the therapeutic milieu of the unit and to look for agitation and escalation and intervene to de-escalate. Separate patients that might be agitating each other, right? Warning leadership of that unit that, right, this is turning into like orange level or red level. This is a powder keg. It's something bad is about to happen. We need to take some proactive steps. And so having BHAs in places besides our psychiatric units, like our emergency department, our medicine wards, not so much in our ICUs. This doesn't tend to be as big of a problem there. But being able to kind of lower the temperature and de-escalate, talking to our residents, talking to our attendings, our nurses, they absolutely love the BHA program. Also, creating kind of standard work around what steps you're gonna take, all the way up to if you need to call a behavioral code, and what's everybody's roles and responsibilities, are using simulation to practice so that it doesn't go wrong, right? I've heard multiple times, 9 out of 10 times it goes great, but that 10th time somebody didn't know what their role or responsibility was, and a nurse got kicked in the face, right? Or a resident got punched as a result. Also, right, for behavioral health, there's mandatory training, right? The de-escalation training. We've created a shorter, abbreviated version of that, 4 hours rather than 2 days, that we're putting all of our emergency department staff through, and then we're going to move to medicine and other specialties as well. We found that to be beneficial as well. They're speaking the same language as the BHAs. They're speaking the same language as our psychiatrists.
I agree with both of you, all the things that you've said, and the BHAs, as you call them. I've worked in institutions where we've had de-escalation teams. You know, we had the psych unit, the same kinds of teams. What I'd like to say is, you said just a little while ago, you know, reimbursement for behavioral health is not good. And, you know, we're treating what the victims now, these people who come and do these awful things, and yes, we want the hospital safe, and we want people to feel safe. Shootings do happen in churches. There was a shooting in an ICU in Philly just a few weeks ago and killed a couple people. The deal is, we need to figure out how in our system to have people believe that mental health is in trouble, and that these people, we need to change our reimbursement so that we're able to treat people who are out there. Some of them don't even know that they're mentally ill. We don't validate it. It's a stigma, but these are the people that are doing things, or people that snap. They could have had something else go on for them. But we've got to look at our insurance system and see what we can do to help people. And also try to have more equity in the community. You know, people say we're products of our environment. Well, if you don't feed somebody, you know, and they, long enough, you know, and they do see food, they're just gonna want to, they're not gonna act like me and you. So we need to look at the inequities in society and put a bigger focus on mental health, treatment, and places for people, housing. You all know it, especially here. We get patients that are admitted here, they have nowhere to go. There's nothing else for them, and we have these patients in our hospital, and then they talk about, oh, well, your bottom line, you're not meeting your bottom line. But we're also taking care of a group of people that if our insurance system were better, this would not be an issue.
Okay, so quite a lot said. We tend to, you know, put up we recognize signage. You know, we have metal detectors on the way into our entrances in some of our hospitals now. We have armed security presence. These are not the measures that are going to address what's causing, or the causation of what's happening in our workplace in healthcare. It's you know, the norms, I suppose, of behavior have changed, have shifted. We need to recognize that as where we're working. That's throughout nationally, probably internationally. I don't want to get too far into that, but we have to realize as well the recognition of, as Dr. Winston said, our behavioral health, our support, our recognition of our mental health programs needs to be stronger in order to work with our society, and that we're able to prepare and treat and recognize those patients, because it's more and more frequent. On the staff side, staff support, the supportive teams recognizing and de-escalation is definitely a tactic towards providing support for staff, having teams trained in recognizing those, have teams recognizing other patients or other scenarios that they're not participating in but been around, and intervening where they can, you know, to prevent that crisis or prevent that from escalation is a tactic again, and that's training and more adaptation of that. I think we need to see stronger in our orientation programs for our staff coming in. our staff orientation, that we address this head on, and calling this out and saying this is something that we're here to support and develop, and we'll continue focus on that. So it's not solved. It's a real problem. I mean, we have, and to burnout, to how it affects our ability to retain. And I've had people leave because they felt that the work environment, and they chose to change positions and jobs and career paths because of feeling that the work environment was not considered safe. They had family advised them about continuing to work on a particular unit in a particular place or in a particular scenario because they felt that we were not providing a safe work environment. So we have definitely more to do. We can, again, put signage up. We can have policies, but it's really about practice. It's about supporting our teams more and leaning into the problem. And as, again, your point about recognizing and having more support for our mental health programs throughout the state, throughout the city, throughout the country. And it also impacts our gun violence in our schools and other areas where we see these things happening. So I wouldn't say we're failing as leadership when it comes to that, but we're not. We seem to be not moving forward.
Thank you.
Excellent, thank you. What do you think, Dr. Naqshbani? We got time for one more? So it's either a speed round,
Yeah.
or does anybody in the audience have any questions? Oh, I see a hand up.
Couple hands.
Is that Dr. Smith?
Come down.
Come on down.
It is.
So first, I want to acknowledge, as the interim chair of the emergency department, I'm extremely proud to see 3 emergency medicine physicians and colleagues on the panel. But I wanted you to talk quickly about interprofessional teamwork during crises. And crises doesn't have to be COVID-19, but the strain on the healthcare system. And what are some of the initiatives that you've done between doctors, nurses, ancillary staff, social workers to build interprofessional teams? Thank you.
So I'll take a stab at that one. I think one of the most important things that we are doing is to emphasize the value of every single role in the healthcare delivery system. So whether you're working in finance, supply chain, you're a PCT, emergency management, everything you do contributes to that service that we are delivering to the community. Historically in medicine, there was hierarchy. Right, so based on your title, you had a certain amount of power and recognition and status. I think we have to do away with that because quite frankly, and I'll speak as an emergency physician, I couldn't deliver care without my team. And there were more than one occasion when the clerk said, Dr. Scott, you need to check on that patient. Or the EVS worker said, hey, Dr. Scott, you might want to check on the guy in the corner. And truthfully, on several occasions, those staff saved someone's life, right? And so the most important thing, I think, is to make sure that every member of the team knows their value and that we respect each other's role in the delivery of care. And so once you create an equitable, inclusive environment, and it's not easy, right? Because people in power want to maintain their power, right? So I'm not saying that this is an easy thing to do, but if you're able to create an inclusive, diverse team where every member of the team is respected for the role that they play, then you're going to create a winning team. And for me, that's my approach to creating a better, more cohesive team.
I would just add to it, people tend not to develop better habits when they're stressed and under pressure in a crisis, right? So it depends on the culture that you create during kind of blue sky times, during normal times, right? Do you have multidisciplinary rounds? Is everybody, treated equally respected, able to speak up and have the psychological safety to speak up? Are there quality improvement initiatives, multidisciplinary? Are people working together to make things better? And if you have all of those things, and I'm a big believer in team steps training, so people have the tools, the language, people know, when other people are using team steps tools, that helps you going into the crisis, right? That this is just how the team works.
Excellent. Dr. Winston?
I didn't plan to comment. I was saying next. I'm trying to help Rami be a timekeeper. However, we need to level the playing field. If you're going to be a team, you're a team. I'm someone who uses the word we more than I, or mine, or theirs, or yours. And when people feel value when you say we, because they feel that they're equal to you. I can remember when I started in leadership, I didn't wear a name tag because I didn't want people to see me as that person. And that's what we need to do as we team build. The nurse, the clerk, the environmental service worker, the physician, their level. People have different skills that they bring to the table, but it's we.
And it's about culture, yeah, and correct statement. Our culture is not in crisis. Our culture is built when we're, when it's our normal other 364 days of the year when we're doing our work. Having a respect and the feeling that you can contribute and speak up and contribute to that. So it's ultimately about not shifting focus about the safety, taking care of our patient or the patient in front of you, or the situation in front of you, and not letting that crisis divert the team away from that. So everybody's got a role to navigate that.
Thank you. I think we have time for one quick question and some quick answers. So please go ahead.
Okay, good morning. Okay, so my question is, what is the healthcare industry as a whole doing to address all of the problems that were described here? For example, you mentioned Baxter and how the hurricane affected Baxter. But several years ago, when the hurricane hit Puerto Rico, Baxter was affected. At that time, we had a crisis in the healthcare system again. And just last year, when Baxter got hit again, it's the same crisis. Nothing was done. Baxter is one of the largest vendors in healthcare. Why wasn't something done after that first hurricane to make sure that there was some backup system there? And similarly, last year, 90% of the healthcare industry couldn't bill at one point. There was just one company that was handling billing for healthcare, throughout the country. What is the industry doing to make sure that those sorts of things are anticipated and can be avoided in the future?
Not enough.
Yeah.
I think reliance on a single source of just product and solutions has, we positioned ourselves poorly because we're trying to favor ourselves over, sole source advantage on pricing, and it's given us maybe an advantage economically because we're trying to pay our bills and match our reimbursement programs deficits. So, but that leaves us vulnerable to instances like this, like a company or a geographic location or an IT solution that, just single source for clearinghouse for authorizations, as you were referring to, and shifting to another vendor, keeping an alternative and a backup system in case of cybersecurity. So having alternatives, but alternatives cost money. So that's, I guess that's the.
Yeah, I think it's going to require policy outside of the healthcare industry to manage this challenge, right? So there's a capitalist drive behind us using the same vendor for the same services, and I believe it's going to really require legislation outside of the healthcare industry to help manage that.
Well, thank you so much. Outstanding panel, amazing discussion. was really great to hear your perspectives, your thoughts about how to lead the organization, how to build the process in place to lead the staff in such crisis. And I love what Sandy mentioned, that the question is not if we're gonna get a crisis, it's when we're gonna get a crisis. And it's very impressive how all those organizations work together, building a process in place to make sure that we are providing our mission, which is serving this community in challenging times. Thank you so much. Thank you, Cindy and Jamie, for leading a really great discussion, and I appreciate you coming to Downstate. Thank you very much. Now I'm honored to introduce our keynote speaker, Dr. Kamal Bajaj. Dr. Bajaj is a transformative healthcare leader who is a catalyzing agent across the areas of healthcare industry. Her work sits at the intersection of quality, innovation, and environmental sustainability. Dr. Bajaj serves as the Chief Quality Officer at the New York City Health and Hospitals at Jacobi and North Central Bronx, and the Medical Director for Sustainability at the New York City Health and Hospitals. She also serves as an advisor for various public and private entities, including the AHRQ, where she was appointed by the Secretary of Health and Human Services in the National Advisory Council in 2022. In addition to her leadership roles, Dr. Bajaj is a professor of OBGYN at Albert Einstein College of Medicine and was recently named one of the Becker's Hospital Review top patient safety experts in 2024. She was also an inaugural National Academy of Medicine Diagnostic Excellence Scholar. Dr. Bajaj's work is regularly featured in prestigious media outlets, including the New York Times, NPR, Modern Healthcare, Becker's Hospital Review, New England Journal of Medicine, JAMA Health Forum. She is also a fellow in the New York Academy of Medicine. Kamal will discuss innovative ways to promote staff engagement in quality and safety initiatives. Please join me in welcoming Dr. Bajaj.
Thanks so much, Dr. Naqshbandi. I realized how many buzzwords I have in my bio. I'm gonna work to change that. Dr. Winston, Dr. Naqshbandi, and the rest of the organizing team, thanks so much for having me here. As I reflect on the many interactions that I've had with Downstate, it's just so nice to be with friends. I was also on my way here reflecting on the millions of things that had to go right for all of us to be sitting in this room today. And just sort of want to acknowledge the fact that, we're taking a moment to reflect on safety and how we can all be better. And that panel earlier was just a beautiful sort of reminder of some of the various sort of opportunities we have to improve safety. So when Rami and I were sort of going back and forth on what to talk about, because there's so much, right, that needs to be done in safety, we were really thinking about, well, how do we honor our culture and our staff and the tremendous work we do every day? And so it's actually very fitting that today I'm going to be talking about the success cause analysis, especially after what we heard at the panel today. So as Rami mentioned, all my sort of disclosures and relationships are mitigated. I also want to give thanks. Some of what I'm going to be talking about today, it takes a whole village. It takes a whole village to do anything that we do. And so I want to acknowledge some of the individuals who have helped support this presentation. So what are our objectives for today? To talk a little bit about the value of a success cause analysis. I'm going to tell you what that is. Describe sort of how we might approach doing a success cause analysis, and then provoke each of you to think about how you might incorporate success cause analysis into the various ways that each of you sort of are involved with the organization. So I certainly, as I mentioned, driving here today, I was like, I'm going to go see my Downstate fam. I hold of all of you that you are intelligent and capable, want to do your best and improve, and I ask that you hold that of me. Is that cool? Yes? All right, thank you so much. I also want to acknowledge that in order for us to, in order to solve the problems in healthcare, many of which were outlined today, it's going to take all of us, each and everyone's perspective. Every single person in this room is valuable and helps contribute to the tapestry that is healthcare. So let's go to talk about healthcare, right? Healthcare is often described as a complex adaptive system. We've heard that word before, right? It's like a coral reef where there are all these wonderful things that are happening, right? The phlebotomy fish and the transportation fish has to work with the sort of the nursing fish to make sure that the patient gets to the radiology reef, right? There's so many things that are happening every minute in healthcare. And so as we think about, well, how do we get better, right? How do we do better in healthcare? It's important to honor that what we're working in is very complex and very adaptive. And it's been recognized that how we approach quality and safety, especially event analysis in safety so far, is limited. This article was shared by, to me by Dr. Benson. Actually, we were in DC last week. And it's from the Academic Emergency Medicine, which talks about some of the problems with how we view medical error. And the point really is that we oversimplify often the complexities of what are deeply interconnected processes. So I mentioned the word success cause analysis, and you're like, man, I don't know about that, right? Let's think about in this campus right now, there are amazing things that are happening, right? Awe-inspiring, right? Rami mentioned that where we're that Downstate is the only transplant center in Brooklyn. Like, we put different people's organs in different people's bodies, right? We make a jaw out of a bone, right? And so all of those things are happening each and every day, right? The ER was mentioned numerous times, right? I'm an OBGYN by clinical background. Every time I go to our ERs, I'm inspired by the work that happens. Because as was mentioned, people are often being cared for their medical problems and also the woes that ail them outside of the walls, right? And also, what about that diagnosis, right? That rare diagnosis when someone pulls together, or a team of people usually pull together all of those pieces and say, you know what? This is what ails you, right? What happens? Oftentimes people will high-five each other. Sometimes they may say, phew, we're so glad that that went well, right? Sometimes you might wonder, wow, that went great. Wonder why it went so great, right? All of the time, there are things that are happening in healthcare. So what is a success cause analysis? It takes root cause methodology, RCA methodology, to understand the factors that contribute to a favorable outcome. Now, some of you may say, it's like what Eric said, right? People have gone to root cause analyses decades ago and, ooh, oh my gosh, right? Like, not for me, right? Or maybe your job function means that you don't go to root cause analyses very often. In this talk, there's something for everyone, regardless of what kind of role you have. This also acknowledges that oftentimes, because of limited bandwidth, because of our culture, because of history and just how we've done things, we focus on the few percentage of events where things don't go well, where the outcome was unfavorable. But how can we learn from those things that go well? Eric mentioned, 9 out of 10 times the behavioral health response team worked perfectly, but that one time it didn't, right? That one time it didn't. My curiosity is, why did it go well 9 out of 10, right? And what can we learn from that? And so a group of healthcare leaders, including myself, were asked in a commentary in the New England Journal to talk about, well, how can we sort of rethink and reinvest in patient safety? And so one of the things I mentioned was, well, how do we learn from all the things that happen, right? How do we learn from lots of things that happen? This is in line with our published frameworks for safe and reliable care, which recognize that leadership, culture, and how we learn, right, are crucial to sustaining improvement. It also is in line with what we all strive to move from a reactive culture, right, which is, I fully honor, is very hard, right, when you're dealing with so many competing priorities, to move to something more systematic and wow, right, if we could be proactive. Health and Hospitals, Jacobi NCB is not there yet, right? But what we're going to talk about today is sort of edging us towards where we want to be. So when I talk, we have, even pre-COVID, we started doing success cause analyses because someone said once, wow, that thing went so well. I wonder why it went well. And it actually turned out there were some very specific reasons as to why it went well that then we could hardwire for the future. And so we've been doing success cause analyses in a variety of different forums. We stopped during the first surge of COVID, but we've been doing them across different sites at health and hospitals. And here are some of the things that we found. The first is that it involves engaging employees in the analysis process, right? Who doesn't want to talk about the amazing stuff they did, right? The clerk who told Dr. Scott, hey, go look at that patient, right? I hope that clerk talked about it, right? Everyone wants to talk about the things that they do. It also gives an increased sense of ownership and commitment. What we've also found is that it allows employees to learn from what has worked well. Like most organizations, health and hospitals does not allow those that were involved in an adverse outcome to be at the event analysis. It's a medical legal thing. But that rule doesn't apply for success cause analyses. So the people that were there can talk about what happened. It also allows for enhanced communication, right? We just talked about how culture is built outside of crisis, right? When you start to be able to have conversations about that other 95% of care, you're building culture for the times that it matters the most, right? When we are in crisis. It also allows for strengthening culture, just culture. I hear that it is Downstate's survey time for culture of safety. Please take your survey, right? Plug, free plug, right? Take your survey. It's also an opportunity to reward and recognize the hard work that people do each and every day, right? It goes from a high five or maybe an acknowledgement at a business meeting to something structural, something that then we can learn from and hardwire. So we wrote a little bit about some of our early successes with success cause analysis, or our early experience through an IHI blog, and actually Becker's recently picked it up. And I'll tell you, we've had engagement with health systems across the world, just recognizing that we do these things anyway, right? We do event analysis anyway. How can we broaden the aperture to really change culture and practice? So here are the steps of an event analysis. Again, if you've never attended a quote-unquote root cause analysis, it's totally okay. Just a reminder that you have to pick the events, think about who's gonna be there and schedule it, figure out the facts of the case, right? And oftentimes that requires talking to lots of different people, or it should require talking to lots of different people. Really think about what happened and sort of what caused it, the root causes, and then how are you going to take those learnings and spread them and measure them to know that change has actually happened. And so what I want to just sort of acknowledge is that we have all the tools to do a success cause analysis because we know how to do event analysis. But rather what we're doing than looking for root causes and problems or failures, those holes in the Swiss cheese, what we're trying to do is, what were the factors that led to success using the same exact methods? And I'll tell you, our risk managers across the system are really bought into this because they have all the tools, right? They have all the tools. So let's begin with a case, okay? So a patient experienced a rare and life-threatening anesthetic emergency known as malignant hyperthermia, right? If I mention the word malignant hyperthermia, like half the room is like, right? Because it's rare, it's really life-threatening, and you need to move fast. So this happened in an outpatient clinic that happened to be on a hospital campus. Sounds familiar? Right? Like a lot of places in New York, they're inpatient, outpatient environments very close to each other, right? The team was able to recognize what was happening, escalated accordingly, administered the special medications, and got the patient to where they needed to be. And the patient had a swift recovery and was discharged a few days later, right? In normal practice, it would have been like, gosh, you all are amazing, high five, that was great, excellent, next patient, right? Next patient, next care. So when we think about event analysis, right, you want to think about events that might have lessons for broader implementation, right? So here's a rare emergency in an uncommon area. That has the feelings of something that might be interesting for other outpatient areas, like high-risk rare events. Also, we've used it for non-clinical events. So as Rami mentioned, I'm the Chief Quality Officer over 2 hospitals. We actually had to merge the QAPI program, or the Quality and Safety Activities, for 2 hospitals. And it went well. And so we were like, oh, well, why did that go well? Right? It could have been dumb luck, but maybe there were things there that helped promote that success. And so in relation to this case, right, malignant hyperthermia, though it is uncommon, was deemed to be of major significance and worth exploring. So let's go to the next thing, the timing of a success cause analysis or the meeting, right? People say, well, we already don't have time, Komal. What are you talking about? And I'm like, I agree. You don't have time. I don't have time. We don't have time, right? So are there existing meetings and spaces that you could take one a year, one success cause in a year, and I promise you it will change your culture and practice. Involve those who were involved in the case, if possible, and invite other areas where lessons might spread. One of the biggest interesting advantages of a success cause analysis is where we invite a lot of trainees, so not just physician trainees, but respiratory therapists, ER, and other kinds of trainees, and people love learning, right? And it's something that sort of, wow, this is an organization that does stuff like this, and I want to work here, right? So similar to the RCAs, the hospital's risk manager facilitated the SCA and sort of did all of the background work that would typically be done during the event analysis. And I encourage you to use the exact same rigorous tools that exist, but flip them on their head for really trying to find reasons for success. And I'll tell you, it's hard. People are like, well, but there was like a 20-second, people want to not talk about success because we're attuned to not focus on what went well and why, right? And so it's hard, it is a brain shift. And so people were very willing to share facts of the case, and so we did a fishbone diagram, right? So I want to take a moment, right? You see things like this when it's like, ooh, root causes, what happened, right? Why did that not go well? In this case, it's, well, why did it go well? Well, there are things like, well, the bag valve mask is consistently located behind the gas machine. There's a direct line from the dental clinic to where a patient needed to go. Equity considerations. Translation services are indeed readily available, and they were utilized, right? An environmental thing. Wow, there was a break room that was adjacent to the sedation suite, and the escalation numbers, who to call when there's a problem, are prominently displayed. As far as methods are concerned, there are daily equipment checks, and there are biannual simulation drills for this specific emergency, right? All of a sudden, you're like, yeah, we do all those things. Right? We do most of those things, right? We do most of those things. So that's what led to success in this unit. But now the key answer is, are they hardwired into the other spaces and places, right? So once you've developed once you've developed success cause factors, right, like root cause factors, then it's important to really think about, well, hey team, what do you actually think of these factors led to success, right? And in this hypothetical case, folks said it was because the escalation numbers were readily available and because we had done simulation-based training. Okay, so that begs the next question, right? Have all of the other areas that are similar to this done simulation tracing? And the answer was no, right? The answer was no. So that identifies specific actions and ensure that these solutions are broadly applicable. So biannual interprofessional simulation drills were initiated. Any latent safety threats, oh, you know what, the BVM is not in the right place, or the medication was expired on that cart, are raised into the usual quality and safety machinery and addressed, right? Then it's a matter of really implementing this, right? Because there's so many good ideas that happen, but oftentimes there's a lot of momentum to want to do these corrective actions because it's not under duress, right? It's not under, oh my gosh, something scary happened. It's our colleagues did something great, right? And we want to honor that amazing work that was happening by doing this in our units. And so implementation, of simulation happened across multiple outpatient areas. And then just like anything, you treasure what you measure. And so measuring what happens. And so in this case, this fictitious, wink, wink, fictitious case, the percentage of individuals who participated in a simulation code was one of the key metrics, as well as the percentage of improvement opportunities that were addressed. Do you know how many signs with the escalation numbers had to be put up? Several, right? Several. Something that you think is so common, right? You walk by those same walls every day, until you need it and you realize it's not there. And then employee recognition is a key part of this, right? I know Downstate, Health and Hospitals, Brooklyn Health, Maimonides, everyone has varying employee recognition and engagement programs. What a cool thing to be like, hey, I heard about that outcome. Great job, right? And not only great job, here's what we did to make sure it happens more often, right? That good outcome is likely to happen again. So in this case, clinical leadership recognized the teams and celebrated even just the fact that an SCA was done. And then again, those improvement activities over time were shared. Now, so what I described, this SCA of this fictitious case, was a standalone investigation. But I'll tell you, in talking to folks across really the globe now about this, people have said, I don't have time. And I want to honor that. And I want to honor that people may not have the ability to even do one a year. And I'm okay with that for now, right? But how can we take SCA-type principles and apply them then into existing activities? So y'all have to do root cause analyses, right? You have to do them. So we all remember this case, right? US Airways landing in the Hudson. So this is a screen grab of the report, right? So wow, what an amazing near miss, right? But by every measurement for the aviation industry, this was a very serious reportable event, right? Why did the engines fail? Why were burnt? Et cetera, right? But what's interesting is that even in this report, the NTSB concludes that professionalism of the flight crew members and the excellent crisis resource management during the accident sequence contributed to their ability to maintain control of the airplane, configure it to the extent possible under the circumstances, and fly an approach that increases survivability of impact. Right? Even in an outcome that you would never wish upon anyone, right? Often the RCAs that we undergo at our institutions, like, pull at your heartstrings, right? Even within those cases, there are opportunities to think about what were some moves that were made that made this, something that was bad instead of really bad, right? And so there's an opportunity even within RCAs. And I'll tell you, it's very hard because people in healthcare, we are not attuned to really talk about when things go well and why they go well, right? It's often just a reframe, right? People want to go to, well, that wasn't available, this didn't happen, so-and-so and that, right? But oftentimes look for it because there will be really important things. It's just to imagine, right? If you infuse these success cause concepts into an RCA, it can reduce the perception of blame and increase active participation. We also have thought about, this is an example from my collaborator at Yale. There were two different units, two different areas, where two members were really kind of at an impasse. There were just sort of personnel disagreements that were happening. The other members avoided raising issues because they didn't want to upset people. And another unit had some of the same disagreements, but it seemed to go really, really well. Well, those people just must be nicer. That's not true, right? That's not true, right? We all come to work to do the right thing, right? But what it turned out was the functioning unit had discord, but they actually had shared agreements not in crisis, that they developed not in crisis, where they had a plan for how they talk about disagreements and how they resolve them, right? So we can use SCA principles for all kinds of things and events that happen. So I really encourage you, the next time you're looking at an unfavorable outcome, I want you to really think about, well, there were probably 10 outcomes or 10 cases like this that went well. Let's learn from those as well. I also think about good catches a lot, right? We encourage good catch reporting, and sometimes we'll track 10 them, sometimes we'll learn from them, but I often really wonder, why did someone take the generosity of time and effort to report them, right? And so we've done sort of very micro success cause analyses in the sense of not a full sort of team and review to really understand, hey, tell me why you were so kind as to tell us that. And oftentimes they'll say, you know what? This happened to me before, I don't want it to happen again, right? Or I think we can be better and I have a solution for you, right? So there are many ways that you can incorporate the ideas or principles of success cause analysis into the work that you're doing every day. So, with that said, I know we're sort of spread out, but I'm going to encourage some audience involvement and participation. I want you to turn to your neighbor. Maybe it's someone you don't know, which would actually be really cool, really exciting, right? Maybe like, hi, right? Make a new friend. We're going to take a few minutes and turn to your neighbor, and I want you to introduce yourself if you don't know each other, but take 3 minutes to really think about what is one principle or one action that you might be able to take, no matter what level you're at, no matter where you're at in this organization, to incorporate success cause principles. And then I'm going to invite a few of you to share at the microphones, okay? All right, 3 minutes, let's go. Hello, everyone. 3 minutes goes by fast, right? And I appreciate some of you were talking about success costs, some of you are catching up, which I'm here for, right? That's success in and of itself. Sometimes the only times we see each other are places like this. And I appreciate people who are checking their phone. I'm here for it. Would anyone be willing to share a little nugget of their conversation? Please come up to the mic so other people can hear it. What's one way that you might think about manifesting success cause analysis principles into your environment? Come on in. Thanks so much. Please say who you are. Let's give it. Yes. The jacket's coming off. This is serious, everyone. Thanks so much.
Hi, how you doing?
Hi.
I'm Carlos, the Director of Emergency Preparedness here at SUNY Downstate. And I believe one concrete action we can take within our department to, applying success cause principles is highlighting our network here. For emergency preparedness, we're a very small team, basically me, Jennifer, and Dr. Daniel. However, emergency preparedness encompasses so many things, and if something happens at the hospital and if we need external help, we're able to get assistance within literally minutes, pick up a phone call. So networking is key to our success here, so much so that we participate in healthcare coalition meetings. Last week we got reached out to actually present on something we're doing here, which is implementing COOP, department-specific continuity of operations plans, which it's a very important and kind of dry topic across healthcare industries, but it's very important because this is a joint commission year, and it's something that they're very much going to focus on, and that's something we want to share with the network and our colleagues here at Downstate. So, yes.
Thank you so much. Let's give it up for him. So, you said your name was Carlos, is that right? Carlos, thank you so much for sharing. There's so much wisdom in what he just said. How many times have you looked up an article and be like, this is a great article, only to realize it was published by someone you know, or is in your network, or is in Health and Hospitals, or is in New York, right? And so so beautifully you said share what you're doing. And I imagine in your presentation you'll share some lessons learned and sort of unpack what you did and how. And the fact that people will come to your rescue, right? You said that if I need help, people will come, right? What a beautiful and important feeling. So thank you for sharing that. Anyone else willing to share? Yes, please, come on through. Yes.
Hi, good morning, everyone. I'm just going to talk about the success root analysis within our unit.
Yeah.
I'm from Labor and Delivery. That's my director right there, Miss Uva.
OBGYN, yeah,
Yes,
appreciate that.
yes.
Thank you for all you do.
It's just like an example, if we have like an emergency, say for example, we have like a serious postpartum hemorrhage or something.
Yeah.
After the situation has resolved, once the patient is stable, we do meet together during the huddle, and we do acknowledge the things, not only the things that went wrong, but the things that also were done right. We do acknowledge the teamwork, because there's a lot of teamwork that has to take place within that situation. So we do acknowledge the teamwork during the debriefing, not only doctors, nurses, but whoever were involved in that case. So yeah, that is a little bit of success root analysis in labor and delivery.
I love that.
Thank you.
And what was your name?
Oh, my name is Rachel.
Thank you so much, Rachel. Appreciate it. So you're taking an existing sort of structure, right, a post-event debrief, and making sure that you're highlighting some of those things that went well, right? That has really interesting manifestations, not just for culture and for practice, right? Labor and deliveries have a lot of new people often, right? So they're learning, oh, that's how you do that. Well, it also has some interesting implications for documentation as well, right? As you're sort of talking about the moves that happened immediately after the case. So triple win on that, right? Thank you. Anyone else willing to share? Please.
My name is Adiola Dabiri from Regulatory Affairs. I was just speaking to Dr. Tena from Pediatrics, and she told me that there was a time when a mother was in problem or in crisis in the pediatric clinic, and it was the registrar that actually noticed something that was going wrong with the patient, and so she got the attention of the nurse and the doctors, and they actually took care of the mother even though it was a pediatric clinic. What we talked about, though, is that she would go back and talk to this clerk or registrar and find out why she actually did and got the attention, what motivated her to act at that point.
Amazing. Thank you so much for sharing that. What a gift, right? What a gift to loop back and say, you know what you did mattered, right? And please tell me, let me learn from your wisdom. Get a little choked up thinking about that, right? Because we all have wisdom. Rami, I'm looking at time. I know what we're good on time. Do I have one more person, one more report out? I'm cool, we have time, I'm hanging. Yes, oh, amazing, we have two.
All right, I'll be quick, so we can have
Two, please, both of you, come up, let's give them a hand. We'll go with you, and then we'll go with you.
Manisa from pharmacy. So usually we have a safe huddle every day. So we talk about, great catches, like example, and we also make it like manage up or shout out just to recognize somebody, who really, and we discuss about that, what else, like anybody want to share or manage up, their colleagues, and what we do pretty much have almost every day of the week.
Wow, that's amazing. Can I ask you a question? Thank you so much for sharing that. How long has that been going on?
I would say at least like a year and a half or 2 years.
And were you here before you started doing that?
Say it again,
Do you remember, were you here or remember how it was before?
No.
Okay.
But yeah,
I'd be curious to hear a little bit from, if anyone from, when you start to institute that alone is a culture shift, but then what are you seeing, right? When people do share, what do you see? What happens?
So they're more engaged. They were talking about, they started to open up about the ideas and things like that. So they're kind of like shy, they want to speak up, but then we kind of like make it feel like they feel comfortable of saying things because it's not something towards them, it's just something to improve overall. So that's what we're trying to improve that.
Excellent, thank you for sharing. All right, our risk manager, final word, let's do this. Thank you so much.
Yeah, I feel obligated to be up there to, the risk management department is responsible for the information gathering, investigating events, and preparing a root cause analysis, to present to the team. And, we, like you mentioned, we do have the tools to do it correctly. And so I'm inspired today by your presentation to, do better at our root cause analyses. We have a wonderful team here, and we're all interested in patient safety. And, we're obsessed with safety. We have our quality huddle every morning, and we go to all our events, and it's a good thing. It's a healthy thing to do, and we're aware of the National Patient Safety Foundation methodology for doing that, and I think we're really close to doing it that way. So we're always looking to improve. So I'm really happy to have met you, and thank you for coming.
Awesome. Thank you so much for sharing. Right? Our risk managers and others really, we gave a presentation for ECRI, which is the Patient Safety Authority for Pennsylvania. And one of the interesting things that they said was, when people see my face, they will often run and hide. Right? I'm sure you get that a lot, right? Uh-oh. Right? And it takes a little bit of, when it's like you're coming and sometimes you have other things besides unfavorable things to talk about, right? It can add a lot of sort of benefit for the folks that are sort of in this every day, right? We're all in this every day, right? But every single adverse event crosses your desk, right? Sometimes it's challenging to think about anything else, right? So I appreciate that, and I'm glad to hear the comments resonated. So, listen, our work, there is so much to do, and we are all in this together, whether it's New York City, right? Whether it's the state, whether it's the country, and really beyond, right? We all have an imperative, and I know we all feel it, right? That's why we're here, to improve quality and safety. And so we're in this together. Feel free to connect. My email's there. Tell me what didn't work about it. Tell me what worked. I'm happy to hear anything. So with that said, thank you so much for the opportunity to be with you today.
Dr. Bajaj, thank you so much for an inspiring talk. I love that how this came right after leadership in crisis. So we always learn how to put out fire. We function really well in doing this, but we learn how not to be proactive, not to be reactive, to be proactive. But actually this talk is taking us above and beyond, not just building just culture when we do our root cause analysis and not point finger and fix systems, but also go above and beyond and look at the root cause for why we did this well. And I think this is really a novel idea. And I love the idea of, we don't have time, but let's put some time actually when we do our root cause analysis, just 10, 15 minutes to say the thing that went well and why they did well in this case. Even with the root cause analysis, even with the disaster cases, there are things went well. And I think we should focus on those as well. So why don't we start now, right now, with our board huddle? Why don't we have like 5 minutes every day in our board huddle to make sure that we point on the thing that went well, and not just point them out, but let's discuss why they went well. Let's start with this just now. We do our board huddle every day, right? So let's do it. Let's do the 5 minutes every day about why this went well. And let's learn from this and share it with the other team while we do our safety huddle, our system safety huddle. Dr. Bajaj, thank you again. It was a great talk, and thank you for coming to Downstate. Our next agenda will be the poster session and the breakout rooms, and that will be in the Fab Hall in the Public Health School. So please visit. There are a lot of great work done, and we can learn from this. So thank you again for joining us, and we'll be back here at 1:30.